Good afternoon, students. This is Dr. Pinaki, faculty with Physiology on this platform Nextillo. Today, we are doing an integrated session on Cushing syndrome. And for that, we have with us Dr.Manira, who will also be taking this particular topic with me. So to begin with, since it's 8th May, Mother's Day, I wish all the lovely mothers a very happy Mother's Day for constantly showering their blessings and good wishes on us. I also take this opportunity to thank Dr. Sunil sir for giving us this particular platform of Nextillo in reaching out to you and giving our inputs in your bright future. With this, I'll start with this particular topic of Cushing syndrome. Now, before beginning with Cushing syndrome, let's understand the physiology of Cushing syndrome and the basics of the endocrine abnormality which is related to Cushing syndrome. So as we all know, Cushing syndrome is related to corticosteroids, and so let's understand the physiology of corticosteroids. This particular diagram is a diagram of the adrenal gland or suprarenal gland, and suprarenal glands or the adrenal glands are the bilateral glands which are present on the heads of both the kidneys, weighs around 4 grams, lies on the superior pole of both the kidneys, and they are divided into, or they are formed by the neuronal tissue as well as the epithelial tissue. The epithelial tissue has a function of releasing endocrine hormones, whereas the neuronal tissue has a sympathetic activity. The adrenal gland, if you divide or if you cut, is formed of adrenal cortex and the adrenal medulla. The adrenal cortex is further divided into 3 divisions. From top to inside or from outside to inside, these 3 divisions are zona glomerulosa, zona fasciculata, and zona reticularis. How can you remember this? Remember GF and R. GFR, which is a glomerular filtration rate for the kidney. Remember, in that particular order, it is GFR, where zona glomerulosa is the outermost layer, the fasciculata is the innermost, is a middle layer, and the reticularis is the innermost layer. Now, zona glomerulare secretes a mineralocorticoid, which is aldosterone. Zona fasciculata, which is a middle layer, which secretes glucocorticoids, and zona reticularis will secrete adrenal androgens. These are the layers of the adrenal cortex. Now coming to the adrenal medulla, which is basically neuronal in its origin. Adrenal medulla is a central 20% of the gland, which has peripheral sympathetic nervous system activity. It secretes hormone like epinephrine and norepinephrine and is responding to the sympathetic nervous system. So that is a background about the adrenal gland in short. Let's understand a little bit more about the 3 layers that I've just discussed. I've told you GFR, that is glomerulosa, fasciculata, and reticularis. Zona glomerulosa, which secretes a mineralocorticoid called as aldosterone. Under the influence of aldosterone synthetase and in the influence of angiotensin 2 and potassium. I will not be talking too much about aldosterone. We'll be concentrating on Cushing syndrome. So we are discussing more in details of zona fasciculata. Zona fasciculata, which secretes glucocorticoids, cortisol, corticosterone, adrenal androgens, and estrogen under the influence of hormone adrenocorticotropic hormone, which is secreted from the anterior pituitary. Again, under the influence of hypothalamic hormone called as CRH or cortisol releasing hormone. We'll be discussing that entire axis again in some time. And the innermost layer, which is the zona reticularis, which is the adrenal androgen, also secreting dihydroepiandrosterone, androstenedione, estrogen, and glucocorticoids, again under the influence of ACTH. All these hormones that I've just told you are the steroid hormones, which are derived from cholesterol, and the basic nuclei of the cholesterol, which is responsible for the secretion of all these hormones, are cyclopento nanoperhydrophenanthrene nucleus. The adrenal cortex secretes primarily C21 and C19 steroids. A lot of questions come on these particular C21 and C19 steroids. So you need to know that C21 steroids are mainly the mineralocorticoid and the glucocorticoid activity, whereas the C19 is having the androgenic, that is the zona reticularis secretion. Now to go ahead, I'll just give you a small tabular format of the secretion of these particular hormones and the mechanism of action. So first we'll go with the production of these hormones. I'll concentrate only on the middle part, that is the zona fasciculata, which is secreting cortisol. So we have cholesterol. In the mitochondria gets converted into pregnenolone. Pregnenolone gets converted into progesterone in the smooth endoplasmic reticulum. Further gets converted by 17-hydroxylase into 17-hydroxyprogesterone. Again, in the smooth endoplasmic reticulum, in the presence of 21-hydroxylase, gets converted into 11-deoxycortisol, and further in the mitochondria gets converted into cortisol. Now, why is this particular flowchart important is because you need to know these enzymes. Deficiencies of these enzymes leads to multiple abnormalities which will be taken care of. So I'll be discussing this entire pathway again in details. So I've told you ACTH, which is secreted from the anterior pituitary, is acting on the adrenal cortex. Now, since we are discussing the cortisol secretion, it is the zona fasciculata. So ACTH responds to the receptor, which is connected with the GS protein, which activates the enzyme adenylate cyclase, which splits ATP into cyclic AMP, which further activates the enzyme protein kinase A. And this protein kinase A will stimulate the conversion of cholesterol esters into cholesterols by activating cholesterol ester hydroxylase. This cholesterol then enters into the mitochondria and gets converted to pregnenolone, which I have told you over here. And this pregnenolone further gets converted into cortisol. So this is the entire pathway of the formation of cortisol from the cholesterol in the presence of ACTH. What is important for you all is to remember these enzymes and also remember the mechanism of action of ACTH and how it activates all these mechanisms. There is further more into this, which I'm going to discuss in this slide. ACTH is a large polypeptide with the 39 amino acid. I've told you it acts on the receptor which is present on the membrane of zona fasciculata, which is MC2R receptor, which activates the enzyme cyclic AMP and protein kinase A, and it activates multiple series. We have immediate, subsequent, and long-term action. Now here I've showed you only one action, that is the final action. There are multiple actions in which there's increase in cholesterol esterase, decrease in cholesterol ester synthetase, increase in cholesterol transport in mitochondria, increased cholesterol binding to P450, increased pregnenolone production, increase in the star protein, which are immediate effects. Subsequent effect is increase in gene transcription, andronoxin, LDL receptor and HDL receptor activity, and in long-term activation, it increases the size and function, complexity of organelles, and increase in the size and number of these cells. So these are in short the mechanism of action of ACTH, which is secreted by the anterior pituitary. Now coming to the cortisol secretion or the glucocorticoid secretion, which is secreted from the adrenal zona fasciculata under the influence of ACTH. So we have cortisol, which is very potent, almost 95% of all the glucocorticoid activity. Corticosterone, which provides almost 4% of the total glucocorticoid activity. Now we also have a lot of synthetic cortisol, which is available in the market. So let's have a look on all those things. We have cortisol, which is synthetic and almost as potent as cortisol. We have prednisolone, which is very, very, very commonly used, especially during the COVID times. This particular drug has been multiple used in frequent events, which is synthetic 4 times as potent as cortisol. We have methylprednisolone, which is synthetic 5 times as potent as cortisol. And we have dexamethasone, which is 30 times as potent as cortisol. So every time these drugs are administered, a lot of side effects because of these drugs is what we are going to discuss in the mechanism and the physiology of action of cortisol. Now a little bit about the transport and metabolism and excretion. The ratio of secretion of cortisol with corticosterone is approximately 7:1. Almost all the adrenocortical hormones are bound to plasma protein. 90 to 94% of cortisol is bound to cortisol binding globulin, also called as transcortin and albumin, which is synthesized in the liver, and its production is increased by estrogen. This high degree of binding with protein slows the elimination of cortisol, obviously because kidneys repel the filtration of the protein, and hence it results into retention of the cortisol in the body. Therefore, cortisol is relatively long t-half of 60 to 90 minutes. The concentration of cortisol in the blood averages almost 12 micrograms per 100 ml, and the secretory rate is almost 15 to 20 milligram per day. This is the entire metabolism. How it is further metabolized is most of the cortisol is reduced into dihydrocortisol and then into tetrahydrocortisol, which is conjugated to glucuronic acid, catalyzed by glucuronidase transferase system and sulfatase. 25% of this is excreted in bile and rest in the feces, and some amount is excreted in the urine. So this is a little bit about the transport, metabolism, and excretion of the glucocorticoids. Now coming to the cellular action of cortisol. So once the cortisol is released from the adrenal cortex, how does it act? Now you all know that cortisol is a steroid hormone. Now since it's a steroid hormone, it can easily pass through the lipid bilayer of the cell membrane. So it can easily enter into the cell membrane, binds with the receptor in the nucleus. So over here, there's a receptor which is present in the nucleus. So there's a hormone receptor complex which combines with the area on the nucleus. So that binding of the receptor in the nucleus results into transformation of the receptor to expose DNA binding domain. The DNA binding domain causes increase in the production of proteins which are targeted for the activity of the cortisol. So there are multiple gene expressions which results into production of mRNA protein and results into further response. What are these responses is what we are going to understand. So to divide the actions of cortisol, we have metabolic actions and we have systemic actions. Now first we'll deal with the metabolic actions. Now you all must have understood or realized that every time the person is on steroids, the glucose level shoots up, the blood pressure shoots up. What is the mechanism is what we are going to understand. So basically, steroids causes increase in the blood glucose level. It stimulates gluconeogenesis. Now what is gluconeogenesis? Gluconeogenesis is production of glucose from the alternate mechanisms or alternate products like amino acids and fats. So obviously it will increase the activity of all the enzymes which are required to convert amino acids into glucose in the liver. For example, it enhances the gene expression of hepatic gluconeogenic enzymes, phosphoenol pyruvate carboxykinase, fructose 1,6 biphosphatase, and glucose 6-phosphatase, and decreases the GLUT4 mediated glucose uptake in the skeletal muscle and adipose tissue. Now, since it is causing production of glucose from the amino acid, you need to mobilize the amino acid. So it also causes increase in the mobilization of amino acid from the extrahepatic tissue, mainly from the muscles. It also decreases the glucose utilization by the cell by depressing the oxidation of NADH, that is nicotinamide adenine dinucleotide, which is required for glycolysis to form NAD+. This elevated blood glucose level is called as adrenal diabetes, and because there's increase in the blood glucose level, it will stimulate the increase in the production of insulin. So that is about the carbohydrate metabolism. Let's understand what is its effect on the protein metabolism. In protein metabolism, it causes reduction in the cellular protein. Generally, it causes a severe weakness and a decrease in the immunity. So basically, it causes decrease in the cellular production of protein, reduction in the protein stores essentially in all the body cells except that of liver. It decreases the protein synthesis and increases the catabolism of protein, which is already present in the body and in the cells, resulting into severe muscle weakness and decrease in the immunity. Cortisol also enhances the amino acid transport into the liver cell by increase in the rate of deamination of the amino acid by the liver, increased protein synthesis in the liver, increased formation of plasma proteins by the liver, and increased conversion of amino acids to the glucose by enhancing the gluconeogenesis. So in short, It increases the glucose levels. It causes catabolism of the proteins. And now we'll understand what is its effect on fat. It also promotes the mobilization of fatty acids from the adipose tissue, increases the concentration and utilization of free fatty acids in the plasma for energy, and enhances the oxidation of fatty acids in the cell. It also causes obesity. It causes a truncal obesity or a mid portion obesity, which is caused by excess of cortisol because of excess stimulation of food intake, with fat being more rapidly utilized. So this is the effect of cortisol on the metabolism of carbohydrate, fats, and proteins. It also has effect on the immunity and inflammatory action. Cortisol blocks the inflammatory reaction to allergic reaction, decreases the number of eosinophils and lymphocytes in the blood. Inflammatory steps are mediated by prostaglandins, thromboxane, and leukotrienes. However, cortisol inhibits phospholipase A2, which is a key enzyme in prostaglandin, leukotriene, and thromboxane synthesis. The anti-inflammatory and immunosuppressive actions are as follows. Cortisol stabilizes the lysosomal membrane. It decreases the permeability of capillaries, decreases both the migration of the white blood cells or the leukocytes into inflamed area and phagocytosis of the damaged cells. It suppresses the immune system, causing lymphocyte production to decrease markedly, and it attenuates fever mainly because it reduces the release of interleukin-1 from the leukocytes. So all these are the anti-inflammatory responses. One of these mechanisms, because of these mechanisms, cortisol or steroids are very commonly utilized as an anti-inflammatory drug in a lot of conditions. Now coming to the system effect. What is the effect of cortisol or steroids on the system or body systems? Now, first and most important, we'll understand the bone and the connective tissue. Now, we all are aware that after the steroid treatment, generally there is increased chances of bone fracture. Why is that? Because let's understand that. Glucocorticoid decreases the intestinal and renal calcium absorption and increases the bone resorption. So obviously the bones become brittle. Both these mechanisms lower the serum calcium secretion, and it lowers the serum calcium. And because of this, the parathyroid hormone secretion is increased. Parathyroid hormone secretion increase results into mobilization of calcium from the bone by stimulating the resorption of bone. So all these activities makes bone brittle, and there are increased chances of fracture after a prolonged treatment of steroids. It also inhibits the osteoblast bone forming effect of the body. Coming to connective tissue, now you all must have realized that after the steroid treatment, the skin becomes very thin and it becomes very fragile. What is the result? What is the reason for that? Steroid inhibits the fibroblast proliferation and collagen formation. Hence, the skin becomes thin and is easily damaged. This happens multiple times when the patient is on long-term steroids, one of the most common side effects which is seen. Coming to the cardiovascular action. Now, I have already told you that one thing that you have to always remember when the patient is on steroid is the blood pressure shoots up. What is the reason for that? The cortisol has a permissive action with catecholamines like adrenaline, noradrenaline, dopamine. So hence it contributes to increase in the cardiac output and shoots in the blood pressure. It also stimulates erythropoietin synthesis and hence increases the RBC production or polycythemia. Coming to reproductive cycle. Now, again, you must have heard this very often that after steroid treatment, there is a chance of a delay in the menses or some kind of abnormality in the reproductive cycle. That is mainly because the cortisol decreases the function of reproductive axis at the hypothalamic pituitary gonadal levels. And that is the reason one has to be very careful in managing the reproductive cycles of the patients who are taking the steroid treatment. Coming to kidneys or the renal system, steroids are ADH antagonist, and it increases the glomerular filtration rate both by increasing the cardiac output and by directly acting on the kidney. Coming on muscle, I've already told you there's a loss of muscle, that is, there's a catabolism of protein which takes place, which results into weakness of the muscle. In addition, it also causes hypokalemia because of the mineralocorticoid action. Hypokalemia is reduction in the potassium levels, which enhances the muscle weakness. How? Because hypokalemia causes hyperpolarization of the membrane potential. Hyperpolarization as in the membrane becomes more and more negative. It becomes below the resting membrane potential. And below the resting membrane potential, it becomes very difficult for it to get stimulated and to get activated. And hence it results into enhanced muscle weakness. Coming to gastrointestinal tract, it has a trophic effect. Motility is reduced. Gastrointestinal mucosa gets regenerated. Gastrointestinal acid and enzyme production is decreased and it stimulates the appetite. So those are all the systemic actions of the steroids, which are exaggerated when the patient is on long-term steroids or if the patient is having a condition called as Cushing syndrome. I'll now give you a very short brief about the control or the regulation of the steroid production. Now, this particular diagram is a hypothalamo-pituitary-adrenal axis. We all know that hypothalamus secretes a hormone which is called as cortisol releasing hormone, which is a 41 amino acid peptide, especially secreted from the paraventricular nucleus. It acts on the anterior pituitary gland to produce the hormone ACTH by the action of adenylate cyclase, cyclic AMP second messenger system. ACTH acts on the adrenal cortex again by the same adenylate cyclase, cyclic AMP mechanism and results into production of cortisol, which has all these activities which we have already discussed. That is gluconeogenesis, protein catabolism, fat mobilization, and anti-inflammatory action. The cortisol has negative feedback activity on anterior pituitary to reduce the production of ACTH. Simultaneously, it inhibits the hypothalamus to reduce the production of CRH. Cortisol, again, a small brief about the pathway. So I'll just give you a revision of the things that we have just discussed. Hypothalamus, which secretes CRH or corticotropin releasing hormone, acts on anterior pituitary to release ACTH, acts on adrenal cortex, zona fasciculata to release cortisol, which has all these actions that we have discussed. It has a negative action on anterior pituitary and the hypothalamus, and it is regulated by stress and the diurnal variations. So this is the physiology part of the adrenal cortex, where we have discussed the mechanism of action, the production, and its systemic and the metabolic actions of the cortisol. Now I'll hand over the session to Dr. Manira for the pathophysiology and the medicine part related to the Cushing syndrome. Over to you, Dr. Manira.
Thank you, ma'am. Thank you so much. Can I please request the host so that I can share my screen? I hope my screen is visible.
Yes. Okay. Yes, your screen is visible.
Okay. Okay. So good evening, students. I'm Dr. Manira Dasmana, and I'll be your medicine faculty for Nextillo. And I think ma'am has now made my work very easy, and now it's going to be a piece of cake for me to discuss Cushing syndrome. So the only thing that we usually get confused in is Cushing syndrome and Cushing's disease. So Cushing syndrome is nothing but the increase in cortisol wherever the pathology may be. It is simple. It is just the increase in cortisol level wherever the pathology may be. It is that. But Cushing disease it is reserved for Cushing syndrome that is caused by excessive secretion of adrenocorticotropic hormone, that is ACTH, which can be by a primary pituitary tumor. So the first thing is that you have to differentiate between what is a Cushing syndrome and Cushing's disease, right? The next thing is, we can see, as ma'am has already told you, the normal physiology is from the hypothalamus there is release of CRH, and from the pituitary there is a release of ACTH, and this ACTH then will lead to the release of cortisol from the adrenal gland. So this is normal. What is happening in Cushing's disease? Now remind you, I am talking about Cushing's disease, not Cushing syndrome. What is happening in Cushing disease is that from the hypothalamus there is a release in CRH, and this CRH is going to pituitary adenoma and to the pituitary and release ACTH. But now already there is a pituitary tumor sitting over there. So there is excess production of ACTH. This excess production of ACTH will lead to the excess production of cortisol by the adrenal glands. So this is the difference between what is a normal physiology and Cushing's disease, and plus Cushing syndrome also. Cushing syndrome, as I've told you, it is the increase in cortisol level, and the pathology can be anywhere in the body. Okay, it can be just simple physiological stress also, right? So the epidemiology is very easy. Cushing syndrome is basically a very rare disease, and it is Cushing disease is caused by an ACTH producing corticotropic adenoma in 75% of the patient. This is a very important point that you have to remember. And Cushing's disease, again, which is a pituitary tumor, ACTH producing pituitary tumor, it is more commonly found in females. Okay, now this diagram has been taken from Harrison. You can see all the causes of Cushing syndrome. So we can see the causes of Cushing syndrome will be now further on divided into ACTH dependent causes and ACTH independent causes, because that is how we investigate Cushing syndrome, and that is how we treat Cushing syndrome also. So in ACTH dependent Cushing's, you can see there is Cushing's disease, which I've already told you, that ACTH producing pituitary adenoma, and you can see the male to female ratio is 4:1. That means females are more affected than males. Okay, and the other causes are ectopic ACTH production. It may be due to ACTH secretion from a bronchial or pancreatic carcinoid tumors, from a small cell lung carcinoma or oat cell carcinoma, from a medullary thyroid carcinoma or pheochromocytoma, and others. So this is a very important slide, and you should never forget it. Okay, and male to female ratio in ectopic ACTH syndrome is equal. It is 1:1. Then we come to ACTH dependent Cushing's. Okay, ACTH independent Cushing's. Okay, in ACTH independent Cushing, that means there is no wrong with the ACTH. Then what are the causes? It is your adrenocortical adenoma, or there can be a very rare causes like macroneuronal adrenal hyperplasia. There can be bilateral adrenocortical adenoma, or there can be unilateral also. Okay, then what about ectopic ACTH production that we need to know? Predominantly, it is caused by occult carcinoid tumors. Okay, most frequently it is in lung in the form of oat cell or small cell carcinoma, but also in the thymus or pancreas or pheochromocytoma. Okay, because of the very small size, these tumors are often difficult to locate, and that is why we have very advanced investigations now to find out whether the ACTH production is ectopic or from the pituitary itself. Okay, and the other rare causes can be medullary thyroid carcinoma or pheochromocytoma. Okay, now prepubertal cases is most commonly seen in boys, and ectopic ACTH syndrome is more frequently identified in men. Okay, a very important point again, a lot of time asked in your MCQs. Okay, only 10% of patients with Cushing syndrome have primary adrenal cause of their disease, and most of these patients are women. Okay, the medical use of glucocorticoids for immunosuppression or for treatment of inflammatory disorders like COPD and what all disorders is the most common cause of Cushing syndrome. So now going to the questions now, please don't mind that I've taken it from a very long back, the All India 1995, but believe me, these questions will be just molded and asked, in the exams. So the first thing that you have to remember is, the first MCQ is the most common cause of Cushing syndrome is. Now you have to be very careful in choosing the answer. See, it is pituitary adenoma. adrenal adenoma, ectopic ACTH, iatrogenic steroids. Now, if in your MCQ there is an option of iatrogenic steroids, then that is the correct answer. But what about the next thing? The next thing is the most common cause of Cushing syndrome is, and you can find that there is no iatrogenic steroids. Then the second most common cause of Cushing syndrome is pituitary adenoma. So you cannot forget it. The most common cause of Cushing syndrome is iatrogenic steroid, and the second most common cause of Cushing syndrome is pituitary adenoma. But a very important thing, if in the question it is written that what is the most common endogenous cause of Cushing syndrome, it is always pituitary adenoma. The most common exogenous cause of Cushing syndrome is your iatrogenic steroids, which are given exogenously from outside into the body. Okay. The clinical features, it is very easy. Again, ma'am has made my work very easy because she's already told you that what are the effects of increased cortisol in the body and how does this happen. So we can see there'll be thinning of hair, there'll be facial plethora, moon-like feces, and then there'll be cerebral atrophy, emotional disturbances. The patient will be very irritable, sometimes depressed, and there'll be enlarged sella turcica, and then there'll be dorsocervical fat pad, which is also known as buffalo hump. Okay. Then there'll be immunosuppression and there'll be hypertension. Which hypertension is mainly there is your diastolic hypertension is mainly there. Okay, so this is again one more thing that you have to remember. There'll be diastolic hypertension and there'll be prolonged persistent hypertension. Then there'll be thinning of the skin will be very brittle, and there'll be adrenal hyperplasia. There'll be central obesity, and then there'll be osteoporosis, muscle weakness, skin ulcers. Okay, and with very poor wound healing. Why? Because of the patient will be very immunosuppressed. Okay, and then muscle weakness will be usually there'll be a proximal muscle weakness. Okay, and osteoporosis. Why? Because there'll be decreased osteoblast activity. Okay, the patient will have diabetes or impaired glucose tolerance, and there'll be striae, especially purple striae of more than 1 centimeter all over the body. Okay, there'll be amenorrhea in the patient. The female patients will complain of amenorrhea and in decreased libido, and most of the times infertility, and there'll be purpura over the legs. Okay, so this is a very important thing that you have to remember. Okay, this is a very important thing, and you can see all the things are marked with a very important cue. Okay, so you can see in skin there'll be dry scaly skin, there'll be loss of hair, there'll be generalized edema. Okay, and in ear, nose, throat there'll be hoarseness of voice and there'll be slowness of speech. Okay, in GIT the patient will complain of weight gain, constipation, there'll be loss of appetite, and there'll be bradycardia. And in cardiovascular system the patient will have a mid diastolic hypertension. A lot of time this question has been asked, and that will be persistent. There'll be breathlessness and there'll be intolerance to cold. Okay, in neurological the patient will have very physical and mental slowness, and there'll be lethargy. Okay, there'll be delayed tender reflexes and paresthesias all over the body. Female reproductive system problems will be the patient may at first will have menorrhagia, but later the patient will always complain of oligomenorrhea and amenorrhea. But mind you, if in your question this has been asked a lot of times, the correct answer is oligomenorrhea. Please never take the most common symptoms of Cushing syndrome is they're going to confuse you. It is oligomenorrhea or amenorrhea. Okay, the patient might have galactorrhea also because hyperprolactinemia, and miscellaneous is like sometimes, most of the patients, sometimes they have carpal tunnel syndrome, and there'll be a serous cavity effusion. Okay, so the other specific features are, which were asked in your MCQs, is there'll be fragility of the skin. Now this is specific only for Cushing syndrome. The diastolic hypertension you can find in a lot of other cases also. Osteoporosis you can find in a lot of other cases also, but specific to Cushing syndrome is fragility of the skin. There'll be easy bruising, there'll be broad, that is more than 1 centimeter purplish striae, and signs of proximal myopathy, which becomes most obvious when trying to stand up from a chair without the use of hand. Then it becomes most obvious. Okay, then the suppression of gonadotrophins with subsequent hypogonadism and amenorrhea will occur, and suppression of hypothalamic pituitary axis will lead to a lower TSH. Okay, now the other clinical features that we have to remember is there'll be excess glucocorticoid secretion, which overcomes the ability of 11 hydroxysteroid dehydrogenase 2 to rapidly inactivate cortisol to cortisone in the kidney. And this cortisone, which will be activated in the kidney, will exert mineralocorticoid actions like diastolic hypertension, hypokalemia, and edema. Okay, a very important thing to remember. Then clinical manifestation of Cushing's do not differ substantially among the different causes of Cushing's. But then again, this question has been so many times asked. In ectopic ACTH syndrome, that means either there is a ACTH producing tumor somewhere in the body, hyperpigmentation of knuckles, scar, or skin areas exposed to increased friction can be observed and is caused by stimulating effects of ACTH or other cleavage products on melanocyte pigment production. So please remember this point. All the good students should remember this point, because now your exams are getting more and more difficult. So they're going to ask you, the very specific points, like what are the features of ectopic ACTH syndrome. So now you know that hyperpigmentation is a very important and very specific feature of ectopic ACTH syndrome. Okay, then patients with Cushing syndrome can be acutely endangered by deep vein thrombosis or pulmonary embolism. Why? Because Cushing syndrome later on leads to a very hypercoagulable state. Okay, then again, we come to some MCQs. Cushing syndrome is not a feature of adrenal carcinoma, oat cell carcinoma of the lung, medulloblastoma, pituitary adenoma. So you know medulloblastoma is not the answer. There are only four five causes of ectopic ACTH production, that are your thyroid cancer, oat cell carcinoma, or small cell carcinoma. There is pituitary adenoma or thymus cancer, but medulloblastoma is not one of them. Okay, and then all of the following are the clinical features of Cushing syndrome except insulin resistance. Definitely, see again, to confuse, they have written over here menorrhagia. No. Violaceous striae, yes. And centripetal obesity, yes. But menorrhagia, no. The patient will always have oligomenorrhea or they will have amenorrhea, but never menorrhagia. Okay. Again, all of the following are true about Cushing syndrome except red striae, increased adrenaline, proximal muscle weakness, edema. The patient will have edema. The patient will have proximal muscle weakness because of hypokalemia and increased catabolism. The patient will have red or purple striae. This is again to confuse you. So always remember red or purple striae. Okay, but there is never an increased adrenaline. Okay, so this is the answer. Cushing syndrome is characterized by all of the except. Okay, there is diabetes, hypertension, proximal myopathy, centripetal obesity. So then obviously it is a PGI question. So then it is all are seen. Okay, features not seen in Cushing syndrome are hypoglycemia, hypertension, frank psychosis, hypokalemia. Everything is seen except for this. There is hyperglycemia. Why hyperglycemia? As ma'am told you, because of there is increase in gluconeogenesis. Okay, and all other features of Cushing disease except centripetal obesity, yes. Episodic hypertension, easy bruising, and glucose intolerance. The patient of Cushing syndrome always have persistent diastolic hypertension. They never have a episodic hypertension. So this is the except answer. Okay, now a very important point, a lot of questions are asked in this are investigations, and a lot of student gets very confused in this. What is low dose dexamethasone test? What is high dose dexamethasone suppression test? The first thing is, if the patient comes to us in the OPD, how do we think, just looking at the patient, that yes, this patient can have Cushing syndrome? The patient will have centripetal obesity, adiposity. The patient will have proximal myopathy, striae will be present. The patient will complain of amenorrhea, hirsutism, impaired glucose tolerance, diastolic hypertension, and osteoporosis. When you have found all these specific symptoms in the patient, then this is a very important chance which will tell you everything. When the patient will come to you in the OPD, the first thing is you have to decide whether the patient has Cushing's or not. So don't straight away jump to to find the whether it is ACTH or non-dependent or adrenal. No, first you have to find out whether the patient has Cushing syndrome or not, right? So for that, three best tests are done, which is circadian rhythm of plasma cortisol, urinary free cortisol excretion, and low dose dexamethasone suppression test. This is very important. So these are the screening tests, and these are the confirmation of diagnosis. When the patient will come to you with these positive tests, then you want to find out that where actually the problem lies. But first confirm whether it is Cushing syndrome or there's some other disorder going on in the patient. So the first thing is the 24-hour urinary free cortisol excretion increase above 3 times the upper normal limit. Many times asked in the MCQs. Dexamethasone overnight test, very easy. What you do is you give 1 milligram of dexamethasone at 11 p.m. Simple. 1 milligram of dexamethasone at 11 p.m. And then what you do is you check for the cortisol level at 8 a.m. And if the cortisol level at 8 a.m. is more than 50, then yes, you have your screening is for Cushing is positive. Or you do a midnight plasma or salivary cortisol, which is more than 130 nanomole per liter. Now, this is where importance of low dose dexamethasone suppression test comes. So we are doing low dose dexamethasone suppression test to further confirm what is needed. Okay, to further confirm that yes, this is my diagnosis. So what you do in this is you take 0.5 milligram of dexamethasone and you inject it to the patient 6 hourly, 6 a.m., 12 p.m., 6 p.m., 12 a.m. And then for 2 days, for 48 hours, you do continuously this thing. And then you see if the plasma cortisol level is more than 50 nanomole per liter, then yes, you are confirmed that this is Cushing syndrome. Whether it is Cushing disease or not, now we'll go further. First, we have confirmed that this is Cushing syndrome. Okay, so this is the same slide that you have to remember. But one thing that in this slide that I want to say is that in normal individuals, the serum levels of cortisol reach their lowest levels at midnight. This is the main important thing. In patients with Cushing, this diurnal variation is lost. Okay, and the serum levels of cortisol remain same throughout 24 hours. And this is why these lines are very important, because this is why your entire different tests are based. Okay, so now what we have done is we have managed to find out that yes, the patient is having Cushing syndrome. Now the next step is we have to find out who is the culprit, whether ACTH is a culprit or there is an adrenal adenoma which is a culprit. So what we do is the second step is we do a plasma ACTH level. In the plasma ACTH level, if it is ACTH is normal or high, if the ACTH is more than 15 picogram per ml, then it is ACTH dependent. If the ACTH is suppressed, if it is less than 5, that means it is ACTH independent. So this is something that you have to remember. More than 15, ACTH dependent cause, and if it is less than 5, then it is ACTH independent cause. Okay, now let's go to first ACTH dependent Cushing. That means you did the ACTH level and you found out that the level is very high. Then what you do? Now, it's common sense. Now what you have to find out, whether it is Cushing disease, that means the ACTH is coming out of pituitary adenoma, or whether there is some ectopic ACTH production that I've already told you, like pheochromocytoma and thymus cancer and any other thing, right? So now we have to find out that. For that, we do some test. Either we'll perform a MRI pituitary, which will show us a pituitary adenoma. Simple. Then your whole thing is over. Then you don't have to do anything. Or what we do is we do a CRH, that is your corticotrophic releasing hormone test. And what we do is we give CRH 100 microgram IV stat. So what will happen is, if it is positive, that means if there is Cushing disease or there is a ACTH producing pituitary adenoma, what will happen is there'll be an increase in ACTH of more than 40% after 15 to 30 minutes of injection of CRH, and there'll be an increase in cortisol to 20%, almost half of ACTH, after 45 to 60 minutes after giving CRH. Simple. And now the other most important test is high dose dexamethasone test. High dose dexamethasone test is that what you're doing is simple. In low dose, how much you were taking? You were taking 0.5 dose. But in high dose, what you're doing is you are injecting 2 milligram of dexamethasone. Okay. And the same way, you're giving it 6 hourly, like 12 a.m., 6 p.m., 12 p.m., 12 p.m. And then what you're doing is if there is a cortical suppression of more than 50% after giving all these things, then you know that it is Cushing's disease. And the treatment of Cushing's disease is very simple. You have to go for a transsphenoidal pituitary surgery. It is very simple, right? And the other thing is, if there is a CRH, if these all tests are negative, that means there is no increase in ACTH or cortisol after giving CRH. The high dose dexamethasone suppression test is also negative. That means there is an ectopic ACTH production. Now we can do all these things also, but the important thing is you find out where is the tumor, where is the ectopic source, and you don't do anything. You remove the ectopic ACTH source. It is as simple as that. But yes, the patient needs a lot of follow-ups. Okay, then coming again to first, what we did was, now we did the plasma ACTH, and now I'm giving you an option that the patient came to you and the ACTH was suppressed, it is less than 5. That means there is a ACTH independent Cushing's. That means there is nothing wrong with the pituitary, and there is no other place which is producing the ACTH. Then what we do? Then we know one thing, that there is ACTH independent Cushing. So what we do is we do an enhanced CT of the adrenals. So if either it will be a bilateral macronodular adrenal hyperplasia, or there'll be a unilateral adrenal mass. if there is anything, the treatment of choices, you have to do an adrenalectomy. Simple as that. You have to perform an adrenalectomy, either bilateral or unilateral. So this is very simple. Okay, where the students will get confused in this ACTH dependent Cushing's, which I've explained very well. Now let's see the questions. Cushing disease is associated with, now Cushing's disease, again I'm saying disease, please, it's not syndrome. Increase ACTH and increase cortisol, increase urinary catecholamines, increase ADH, decrease ACTH and increase cortisol. Now a good student who has studied very well would know that the answer is A. And why it can't be D? Because if there is decrease ACTH and increase cortisol level, this will be fine if their cause is adrenals. If there is any adrenal tumor, or if there is, that means this is the cause. Then you will have this picture of decreased ACTH and increased cortisol levels. Okay, so again, the other question is about Cushing syndrome. True is low dexamethasone suppresses cortisol secretion. Okay, then if CA of the adrenal is more common than adenoma, okay, pituitary adenoma size is more than 2 centimeter, increased ACTH secretion is commonest endogenous cause. Okay, so I've already told you so many times, the most common exogenous cause of your Cushing syndrome is iatrogenic steroids, and the most common endogenous cause of your Cushing syndrome is increased ACTH secretion. So you know the answer now. Okay, the treatment part is very easy. Cushing disease, that means if there is ACTH producing pituitary adenoma, your treatment of choice is selective removal of the pituitary corticotrophic tumor. Okay, usually by transpenoidal approach. This results in the initial cure rate of 70 to 80%, and long-term follow-up is important. Okay, as relapse is very common in significant number of patients. Okay, what about non-ACTH dependent? Okay, then what we have to do is we have to perform a bilateral adrenalectomy. Okay, and this will give a patient very immediate cure, but then the patient will be requiring lifelong corticosteroid support, and you have to counsel your patient about that. Okay, after surgery, what is the most important thing? After successful removal of ACTH or cortisol producing tumor, the HPA axis will remain suppressed for a very long time. So again, patient counseling is very important. And then hydrocortisone replacement needs to be initiated at the time of surgery and slowly tapered following recovery, and to allow physiological adaptation to normal cortisol levels. Okay, and the HPA axis may require many more months or even years to resume normal function. Okay, then what are the oral agents which are used in practice nowadays? It is your metyrapone, your ketoconazole, your metotane, and your etomidate. Okay, now metyrapone inhibits cortisol synthesis at the level of 11 hydroxylase. Okay, and what is the starting dose? You can go till 6 grams, but the starting initial dose is always 500 thrice daily. Okay, or we can give an anti-mycotic drug like ketoconazole, which inhibits the early step of steroidogenesis, and the dose is 200 mg, again thrice daily. Okay, what is metotane doing? It is a derivative of the insecticide DDT and is an adrenolytic agent that is also effective for reducing cortisol. Okay, and most commonly used in the context of adrenocortical carcinoma, but low dose treatment has also been seen in benign Cushing's. Okay, with that I come to the question which is very important. A chronic smoker, see again, the history has been, the history has always been molded and asked in your NB examinations. Okay, a chronic smoker presented with hemoptysis, he also gave a history of hypertension and obesity. Lab data showed raised ACTH levels which are not suppressed by high dose dexamethasone. The cause of Cushing syndrome in this patient is, now they have already told you that there is high dose dexamethasone, they are not suppressed. So the cause of Cushing syndrome is ectopic ACTH secreting tumor. If it would have been that if they are suppressed, not nahi hota or likha hota, they are suppressed by high dose dexamethasone suppression test, then the answer would have been your pituitary tumor, any pituitary adenoma. Okay, then the differentiating feature between ectopic ACTH secretion and Cushing syndrome is, now this is very easy. Now I should tell you this thing, that ectopic ACTH tumor has some characteristics which are found, which is it has hypokalemic, hypochloremic, metabolic alkalosis. The pH will be high, chloride will be low, and the potassium will be low. So the answer for this is hypokalemic alkalosis. Okay, so the patient with ectopic ACTH secretion, the first clinical feature that I told you before was that the patient will have hyperpigmentation of the knuckles and the skin. Okay, because it reacts more with the melanin pigment. And the second feature is that of ectopic ACTH is that potassium will be low, chloride will be low, and the pH, or there'll be alkalosis in the patient. Okay, then the next question is, which of the following is the earliest manifestation of Cushing syndrome? Ma'am has already told you one thing, and I'm also repeating this to you. In my previous slide, I've told you that the most important and the first thing to happen in Cushing syndrome is loss of diurnal variation. Loss of diurnal variation is the first thing to happen in Cushing syndrome. Okay, that means the low levels of Cushing, the low level of cortisol which falls at night, the cortisol level becomes the same throughout 24 hours. Okay, so this is what you have to remember, and this is all about Cushing syndrome. Thank you.